The good news is that when we have when discoveries in the laboratory, for example, the ones that Dr. Fauci summarized, when they can be made available to those who would benefit from them. And again, that one day will be prevention, like vaccines. Today, better diagnostics, better therapies. When we can deliver them effectively, the impact is quite stunning. We've heard, Tony mentioned, Dr. Fauci mentioned Rwanda. Rwanda, just 20 years ago, as you know, was thought by many to be a failed state. Genocide was still ongoing 20 years ago. Highest mortality, infant mortality, maternal mortality in the world, lowest life expectancy, probably the poorest country on the planet. And over the last decade, programs like amfAR's Global Fund have allowed the Rwandans to roll out effective delivery programs for, among other things, the diagnosis and treatment of AIDS, malaria, and tuberculosis. Those were the big three killers after the end of the killing and the genocide. And it's because they rolled this out across the country with a special focus on the poor, the rural poor, using community health workers to reach and go that last mile, that over the last decade they've registered the steepest declines in mortality ever seen, as far as I can tell, anywhere, in any place. So that should be, and part of that is due to declining AIDS mortality. It's not just declining AIDS mortality, it's all cause mortality. So, for the frontline workers, doctors, nurses, social workers, a lot of social workers here, by the way, community health workers, local village leaders, local authorities. The frontline workers need the influx of new tools and resources to put in. We need staff and stuff, and we have that. We can do our work. And
let's talk about that. Give us a picture of how it's changed, whether Rwanda or Haiti or both.
Well,
How's the delivery? How's the prevention changed?
Well, I was in Haiti at the time that Dr. Fauci mentions. In fact, my first year at Harvard Medical School, this young guy, this new director of the NIAID showed up. 1984, the first year. And he said something that I'll never forget. And this is a crowd of medical students, first year was 24, maybe 24 years old. And he said, there are two kinds of researchers, those who work on AIDS and those who will work on AIDS. And we just, it's that Italian, fiery gentleman. And by the time that I had already spent a year in Haiti, before medical school, between college and medical school. By the time I was doing my clinical rotations, toward the end of my medical training, I was moving between Haiti and Harvard hospitals, like the Brigham and Women's Hospital, but still am today. And the hospitals on both sides of that division were full of young people dying of AIDS. It was the leading infectious killer of young adults in the United States and the leading infectious killer of young adults in Haiti. So to me, that is just a very, very difficult time. And I'm saying for me, as a clinician or a doctor in training, imagine the people who affected more directly their families and loved ones. It was just really a grim era. And that was true, and again, all major cities in this country, and certainly in Haiti as well. And then to go forward just a few years, I graduated in 1990 from medical school and started what's called an internship residency. We go and train in internal medicine and infectious disease. In many ways because of AIDS, because I had seen the devastation of AIDS in Haiti and in the States. I remember very clearly in the mid-90s, I was finishing my infectious disease training. This new therapy came along. So we used to call it AIDS cocktails. I don't hear that term very much And the hospitals cleared out in Boston, people stopped them, and went home. And some of those patients, I still know to this day, that didn't happen in Africa. It didn't happen in Haiti immediately. And it wouldn't have happened if the world kept on going the way it did. But something changed, and it was described very modestly by Dr. Fauci, and that change was resources to deliver AIDS prevention and care in Africa. And that's what turned things around, were programs like PEPFAR and the Global Fund. And without them, you can't deliver the deliverables. Now, I would also add, I think we've done a better job for example, in Rwanda than the United States in keeping people in care, and that's why we see sharper declines in mortality.
Why is that? Why a better job?
I think if I had to choose just one answer, and you already see that concision is not my strong suit, I would say community-based care, community health care. Because we don't have a tradition in the United States, or in lots of other countries in the world. Russia was just there last month. There's no tradition there either of, Susan said, she talked about moving from sick care to health care. We have a sick care system. I actually like being someone who takes care of sick. I like working in hospital. My own work is primarily hospital-based, but it's not about me. It's about the system of care delivery. And in Rwanda, where there weren't hospitals, doctors, and nurses, which is a bad thing, because we need them, there was also a clarity that community-based care would require health workers. And that's the majority cadre of care providers there in terms of numbers. And that's why you can reach in people's homes, neighborhoods. That's what we need in the United States.
And you've talked about this and you've written about it, but how does it work? What is community-based care? Why does it work?
Well, if you go back to Dr. Fauci's slide, the pyramid, some people talk about a cascade going from diagnosis. We had 1.1 million people there, and a substantial minority of patients who have been referred, who know their diagnosis. And again, I'm just talking about HIV. We talk about epilepsy, you talk about diabetes, you talk about any chronic ailment, especially one that affects organ and otherwise organs. So to say, how do we go from good diagnosis, obviously we want prevention, but I'm saying for those already sick, how do we go from there to keeping the great majority in treatment? How does it work? Well, there are lots of places to diagnose an illness like this. In the world, probably it's prenatal care is the number one. I don't know if that's correct. Because of the way programs are structured in a lot of places, I don't know if CDB can tell us. And the funding, again, for prevention of mother-child transmission, a lot of women are diagnosed in prenatal care, and then they bring in their partners who are diagnosed perhaps in the clinic. But to get from that moment to proper therapy, stay on care, it's not a doctor or a nurse or a social worker or a psychologist who does that. It's someone who's closer to where the patients live. And so, to me, that looks like a community health worker. And how to connect the clinics and the hospitals with community health workers. It's not straightforward, it's not easy. But first you have to make sure and recruit, train, and pay community health workers. And they can't do 30, 40 hours a week as volunteers. And that's been a major ambivalence in the United States as well.
You've also talked in connection with this about this whole idea of accompaniment, about having somebody there. It sounds like it would be hard to do that in a place like Haiti, in a place like Rwanda, to have community-based care and to have the sort of apparatus that you're describing. But you're saying it's very possible and that it has happened. Why is it?
First of all, certainly it is possible. I think the notion of accompaniment, I first learned it in Haiti 25, 30 years ago when I saw the same sort of tuberculosis. We built a clinic in the middle of central Haiti. I was still in my 20s, the we here as my Asian co-workers, supporters for partners in health and all over the place. We built a clinic, and you put in a lab and say, hey, we can diagnose tuberculosis. This is before HIV came along to trouble our world. And it's exciting if you look and say, oh, this patient has TB, we have the treatment, it's free, we didn't even sell the treatment. And then you find out that you can't even account for half of them, just like the treatment cascade that Dr. Fauci showed. That is very sobering. So you go and say, well, where are they? Where are the patients? So they didn't get teleported to Mars, and some of them most of them are still alive. They couldn't get back into the clinic. They couldn't find someone to watch their kids. They couldn't get transportation. And when you redesign the program, to have this human-centered design where you're focusing not on what's good for the doctors and nurses, but what's good for the people, the patients, and I'm not even about the patients, then you redesign the program. Say, well, how about we move all the care to them so that they're not inconvenienced, so they don't have to come in to get an injection. Back then, we were using injectable drugs. And so we redesigned the program completely in Haiti to focus on community health workers, not to exclude physicians and nurses. And that's when we saw the turnaround. And of course, that was before AIDS, and when AIDS came along, we said, well, we know how to treat tuberculosis correctly. Let's use the same model.
But you have to have resources.
You do. You have to have resources. And it's actually less expensive to give higher quality care than to give poor quality care. I mean, it's very expensive to give poor quality care in a country like ours, because we don't do well with chronic disease, which is the burden of disease in this country, and it's costing not only in human terms people who are doing poorly, they're not. It's costing an enormous amount of treasure, and
Because of prevention.
prevention and care aren't integrated, one, but also we don't have a good system to take care of people with chronic illness, because that would require, again, recruiting, training, and retaining community health workers. And not social workers, doctors, nurses, and psychologists, but people who actually move out to where the patients are. Now, that's not how you manage, orthopedic trauma, right? I'm not saying it is a panacea. I'm saying when you have a heavy burden of chronic disease, AIDS is a famous chronic infection. It's a certain tuberculosis. But the majority of these chronic infections are not communicable diseases. And when you have a big burden of that, you need to redesign the system. And that's, I think, where we are in the United States. We can learn from Rwanda, we learn from Haiti, we learn from other places, and AIDS particularly, where the resources were put in, but it was the outcome that was, and the outcome we wanted was decreased deaths, decreased transmission. It wasn't, designed to, let's say, have the cheapest system. It turned out to be the cheapest system as well, but it was the outcome in mind. So if we say the outcome is less disease, suffering, disability, then we're going to have to redesign our system in the United States as well.
Do the folks you work with on a day-in, day-out basis, whether it's in Haiti, whether it's Rwanda, do they recognize the advances that have been made? They recognize that things are better today?
It's stunning to them, in fact. I mean, in Rwanda, again, the place I'm just mentioning, places where I've worked personally, in Rwanda, Malawi, Lesotho, everybody there, the care providers, physicians, nurses, community health workers, of course, they remember what it was like only 10 years ago, only 8 years ago in their countries. And just like I remember what it was like 20 years ago in Boston. So absolutely, there's enormous recognition. And I think my colleagues who work internationally, and we're going to hear from Ambassador Burks as well, there's enormous recognition in the rest of the world that there's been massive improvement. Of course, people also see where we need to go, or why we can't take a victory lap.
And how do you see that? I mean, we heard Dr. Fauci describe that from his perspective. How do you see that?
Well, I still know the people we started on therapy 15 years ago in Haiti. In fact, I saw on Monday morning, I went to a small hospital in central Haiti, and we built apartments in health and built with the Ministry of Public Health Authorities. And I ran into a patient. I don't know what he was doing there. Maybe he heard I was showing up, but
and some of them are actually still on their first line therapies because they have community health workers. The rate at which they, as they say, become resistant, in other words, the rate at which the strains infecting them become resistant, is slow. But that's what it feels like to me. It's like, hey, there's my former patients. They're still patients, mind you, but they're not my patients. They really don't need me, and they don't. They're working. They're taking care of their families, and my coworkers across the world, feel that. So what it feels like for me is it's great. And when you lose someone or you find out about a new infection, that's failure, and we can know a lot more about what causes failure as well, much more than we did 10 years ago.
So how do you see what more needs to happen? What message do you bring to the people in this room and beyond about what needs to happen? Not just in Haiti and Rwanda, but in those places that don't have the kind of system in place that you think works.
Well, since we're in this building and in this city, I think the message is not the same one that I would give to my colleagues in Haiti or Rwanda, or they're the same ones, because there's more than one. This is the epicenter of rolling of a program like PEPFAR. Right? PEPFAR came from here, this city, and it has saved millions of lives. PEPFAR is the largest global health program, as far as I can tell, the largest health program in human history that reaches across all these borders. Someone said, what about the efforts around the Panama Canal to get rid of mosquito-borne illness? There's nothing that compares to PEPFAR. And there are multilateral programs too, like the Global Fund. And that also requires support from the United States. So to me, that's I want to say to anybody who listens, I hope everyone understands how profoundly effective these endeavors have been. There was widespread skepticism, by the way, just a decade ago, in many expert circles, public health circles, as well. It's not sustainable, it won't work, you can't do things in poor countries, you don't have the healthcare infrastructure. We heard all of that. It was just widespread predictions of defeat. Fortunately, those voices were diminished. Again, AIDS activists played a big role, as did scientists, clinicians, and those who supported, again, this public money is being put to PEPFAR. So the big message is we need everybody to understand how profoundly effective this has been. And then we say, it's the biggest program as well. It's going to change the face of medicine and public health in general. On a basic science level, we're going to know much more quickly how to deal with hepatitis C because of these investments in HIV, right? We're also going to know better how to treat an infection, another chronic infection like that, or other chronic illnesses, major mental illness, epilepsy. So the big message here is, and that's why amfAR has organized this gathering, is we need to sustain and support this kind of investment in programs that seem to some people of little concern, very distant. They're not.
And that's the final thing I want to answer, because many people look at AIDS and they think, gee, isn't that something that we kind of put away for the time being? And we've made so much progress and people can live a lifetime with it, and we really even worry about it. What do you say?
I say that's wrong. And just like the same claims made about tuberculosis, tuberculosis is gone. When people in, again, some policy circles and even medical circles were saying, well, tuberculosis is a disease of the past, at the very time they were saying that, it was the leading infectious killer of young adults in the world, until it was surpassed by HIV. So those kind of claims, it's not important. It's obviously you can't sustain that if you're moving between a place like Harvard and Haiti. You can't sustain the fiction that it's important in one place but trivial in the other, or you can intervene in one place and the other. It's not, when I say not sustainable, to me that's just not psychologically and emotionally sustainable. How could you be a doctor or a nurse or a human or a mom or a dad or whatever and just say, we can do something here but nothing there? And that's the great drama of why we're calling it global health, is that we're in this interconnected world, and tuberculosis came back in the United States, as people know, after we stopped public funding of tuberculosis. We completely stopped what were called block grants for tuberculosis in the 80s, or maybe it was the 70s, gone funding. And what happened is major epidemics of drug-resistant tuberculosis in every American city. New York particularly hard hit, as you'll remember. But all the big cities, and that was again the state saying it's not important. And I think we run that risk, with some of these programs. And one other point, I think, in a place like this, in a meeting like this one, with the people gathered, is we also have to resist this tendency to balkanize, right? Like HIV versus tuberculosis, right? It's them, the microbes versus us as a species, right? It's not one pathology, versus another. And that's why, the leadership we have here is really thinking hard about, again, building those systems, like, in Rwanda, build a health system in the United States that can allow us to respond, not just with the basic science, but also with the clinical care, all the way to where people live, so they really benefit from these discoveries. That's the big delivery challenge